Hi, everyone. I'm Dr. Shivani Kumar. I'm a board certified vascular surgeon at Tufts Medical Center in Boston. I did my medical school at UMass in Worcester, Massachusetts, where I found excellent mentorship and then pursued an integrated vascular surgery residency at Mount Sinai Hospital in New York City. There, I found a passion for, complex endovascular limb salvage and have really adopted that into my practice here in Boston at Tufts. And today we're going to be going over a discussion on IVL, in the iliac vascular space, quick discussion and then some case review to highlight some of what we do. It was really through residency and training. I trained at a 05 integrated program at Mount Sinai in New York City, where we had access to wide breadth and depth of endovascular technology. And when IVL was starting to be introduced, my mentors at Sinai started to use it very frequently, either to treat high calcified lesions that were non-responsive to the traditional means we had before, whether POBA, atherectomy, or DCB. We also would try to use IVL initially in the iliac space, to get device delivery up, whether for TAVRs, TVARs, EVARs. So it really expanded our ability to treat patients with different technologies and different end results. So, being an early adopter of IVL and being at an institution that really gave us opportunity to experience new technologies is how I first got into IVL. I found that it was very effective, it worked, and it was safe. And then I started to use it more and more as I built my own practice here. Well, as we all know, the iliac arteries are challenging because catastrophic outcomes can happen if we have dissections, if we have a rupture in that space, if it's a tight lesion and you end up with an iliac on a stick. Those can be very life-threatening emergencies to a patient. And so oftentimes we are conservative in that space and we don't always get desirable outcomes. With the introduction of IVL, it has allowed us to treat the iliacs with more definitive treatment because of the low pressure atmosphere and balloon. So the challenge for me personally in the iliac space is risk of dissection, risk of rupture, with a high pressure balloon. It's challenging because you need to maintain your bifurcation to get up and over. If you have to stent you and a highly calcified lesion, your stent will not go to profile. If you're delivering a device, for other pathology, right? Aortic dissection, a TVAR, a valve, an EVAR device. So getting things, through that bed, it's a gateway into the body for other pathology. So there's several challenges in treating these iliacs and doing so safely. Calcium being one of the biggest ones that prohibits us often from getting definitive treatment that's beneficial to the patient. So when do we decide when to stent the iliac, use standalone PTA, use IVL? What has been the evolution of treatment, endovascular treatment in the iliac bed? I think about a decade ago when I first started doing peripheral intervention and IVL was not yet widely adopted and we didn't have, the technology that we have, we would be very conservative, right? We would, treat with lower pressure balloons. We would always, have a stent in the room ready to go as a bailout option to if we ruptured or had a problem. So conservative. And it was usually plain balloon angioplasty, bailout stenting, or if we had, recoil of lesion, we would try and get a stent in there. Now, stenting in a calcified bed that the stent doesn't open to profile, that's almost worse than not treating it at all because now you have a crunched stent, it's kinked, you're already kind of setting yourself up for failure down the line. With the introduction of IVL, the L6 catheter which is safe, is able to deliver multiple pulses and really modify the plaque. I always like to describe IVL as if you have a big iceberg, this kind of takes that iceberg and breaks it up into crushed ice. Crushed ice you can mold and you can move. So with the introduction of IVL, now my algorithm is very frequently going to IVL first for plaque modification and using that as a bridge to my definitive treatment of, if I have to stent or getting a device in, taking completion pictures, stenting on the way out. So it's really become my kind of first line go-to for calcified diseased iliacs, and also because of the safety profile and very low risk of rupturing. So how has Shockwave adapted and impacted our definitive therapy in the iliac bed? Any device, there's new evolution, there's new iterations of it. And the L6 balloon specifically is in larger diameters. So traditionally we only, the max I think was 7, 8, and now we can go like there's 8, 9, 12 almost. And so that allows us to open up a balloon that really gets wall apposition to a large iliac. It's sized appropriately. You're able to get the balloon right up against the calcium and definitively deliver that shock and impact to the calcified lesion. So the appropriate diameter sizing has allowed us to really apply the technology how it's supposed to be used in the iliac bed. And with the introduction of L6, it gives us the appropriate size. It is a faster emitter and allows us to rapidly treat. And, we always want to never rush through a case, but you always want to move effectively and have no wasted motion and continue to make progress in a case, especially if this is a bridge to definitive treatment, right? We need to shockwave to place appropriate kissing iliac stents. We need to shockwave to improve inflow for a bypass. We need to shockwave and open the iliac artery up so it can appropriately take that large device delivery for a ZFAN or a TVAR or iliac or branch device to definitively treat the patient. So Shockwave has opened the door for my practice, at least, and my patients who have highly calcified iliacs, and has opened the door safely, and the L6 especially, to be able to deliver definitive treatment. So what evidence and data helps to kind of impact our algorithm when treating calcified iliacs? And how do you choose what to do and kind of what device to use? So oftentimes when you just do a plain balloon angioplasty, you don't have great long-term patency with that. There's recoil of the vessel when it's calcified, and you may not get full kind of luminal gain that you're hoping to get. With device selection, for me personally, I always look at safety profile of the device and what complications may you run into with that. So with anything in the peripheral space, you look at, does this cause embolization? Am I going to end up compromising my outflow? Am I going to leave this patient worse than when they came in? Dissection profile, like if I bring this balloon up to nominal and bring it back down, am I going to end up with a dissection where I have to stent, where I need a bailout procedure? And then rupture, how frequently does blowing up a balloon in this calcified bed cause rupture? And so, with the data that's been out from Shockwave and from some of these trials, that has impacted my favoring using the IVL technology, because the rates of rupture, dissection, and also embolization, where you may lose outflow, are very, very low, if not non-existent. And so that has impacted why I most of the time defer to using IVL when I see on a CAT scan a highly calcified iliac lesion in a patient who would benefit from it. Every practice is different, whether you're working in an OBL setting, a community hospital, or an academic setting. As someone who works in the academic setting, allowing us to get product on the shelf and reimbursement was fairly straightforward. We did a value analysis to the hospital with Shockwave, and the new codes that have come out with IVL and the reimbursement. My local reps or your local reps can provide information to you and help facilitate those conversations. And if you look, we never make patient decisions or care decisions based on what reimbursement are we going to get. We always try to say, what's going to be right for the patient? What's going to help them? What's going to give me the best outcome? And so when you look at the data of safety, efficacy, and outcome and durability of long-term patency and amputation-free survival, when you look at these things and you compare the cost and reimbursement, then you have an argument as to why this technology or any technology is beneficial for you to have. And so if you look at the billing of it, a stent and balloon only, you get less reimbursement than if you do Shockwave or IVL. Again, not a reason to do any kind of intervention, but it does help, make your case to a hospital or institution to stock product on your shelves. And it was quite easy at our institution, and we were able to get approval. Here, is some of the comparison between PTA and a cutting balloon versus IVL versus atherectomy. And so these are the reimbursements of it. And you can present some of this data in these slides, to your hospital value analysis committee, have a conversation and explain that the iliacs don't have a lot of options besides balloon, right? We know atherectomy is not designed for the iliac space. It's not a place where we frequently use it with often indications. There's always exceptions, but very frequently it's only been plain balloon angioplasty until we've had the adjunct of IVL, which is helpful to kind of discuss with your analysis committee. So I'd like to share with you all some cases specifically looking at calcified iliac arteries and in some specific patients that I think will help highlight the use of IVL in the iliac space and where and when is it beneficial. So our first case, we used a Shockwave L6 in the left common iliac artery. So let me tell you first about the patient. This is a 56-year-old gentleman who came to my office who had severe right lower extremity lifestyle-limiting claudication that then progressed to rest pain. He had a history of hypertension. He was a former smoker. He felt he could not really walk well. This eventually progressed to rest pain and had a 30-pack year history. He had no prior surgeries. He was on Plavix. And on physical exam initially, he was well appearing. He had a palpable 1+ left femoral pulse and Doppler signals on the left lower extremity. On the right side, he had a non-palpable femoral pulse and Doppler signals at the feet. We started with non-invasive studies and we got ABIs, PVRs, and it showed the right side with severe arterial disease with an ABI 0.49 and the left side with mild disease of an ABI 0.87. So initially I told the gentleman, let's do an exercise walking program. Let's see how we do. And after 2 years, he failed conservative management and he progressed to rest pain. And so I told him at this point, your options are a continued walking program, really not going to help your rest pain, and we've already tried that, an iliofemoral bypass, an endovascular attempt to cross the right common iliac artery and stent it, or a left to right femoral-femoral bypass. And we obtained some preoperative imaging, given the fact that he had non-palpable femoral pulses. So this here is a CTA of the abdomen and pelvis. On screen left, you can see kind of the origin of the common iliac arteries. The right common iliac artery is completely occluded and stayed occluded till the common femoral artery. And on the left side, you see high degree of calcium on the left iliac artery, which likely explains why the patient didn't have a strong left femoral pulse. These are lower down slices. You see the left iliac artery has high degree of calcium. The right stays occluded. And on screen right, you will see that the common femoral artery regains patency on the right side. And on the left side is also patent with a little bit of posterior calcium. So the patient did not want open abdominal surgery. He wanted and the iliofemoral bypass was not going to work as the iliac was occluded all the way up to the aortic bifurcation. So this would have really been an aortofemoral bypass unilateral. And he opted to pursue a femoral-femoral bypass. And in order to improve the inflow for this, we performed an 8 mm Shockwave L6 angioplasty of the left common iliac. We then placed a 10 by 29 BBX and 9 by 29 BBX stent to improve the inflow, and then performed a left to right femoral-femoral bypass with 8 mm ringed PTFE. So here are some angiographic images. The first one on screen left is the initial angiogram after we had done the left common femoral artery exposure. We have a retrograde sheath in place, and you see the highly diminutive left common iliac artery, and you see the absolute cutoff on the right side and occluded right iliac system. In screen center, you will see us take an image from the pigtail catheter after the left shockwave angioplasty was performed with the L6 balloon. You see significant improve in that luminal gain. You don't see that calcium kind of impeding on it. You see kind of a one smooth vessel. And then you see our post-stenting, and now we have appropriate inflow, palpable pulse, and brisk bleeding out of that sheath. So 1 month post-operatively, he had a patent stent with no high-grade stenosis and a patent bypass. He had palpable femoral pulses on both sides and palpable pedal pulses. He no longer had rest pain. He no longer had claudication. He was back at the gym, and he was maintained on aspirin and a PAD dose of Xarelto. I saw him recently 6 months post-op, and he's doing well and remains asymptomatic, and his arterial studies are all within normal limits. Our second case is an example of using bilateral L6 shockwave and kissing iliac stents. So this is a 70-year-old woman who presented with bilateral lower extremity rest pain. She was hypertensive, had CAD, paroxysmal afibrillation, tobacco use, and presented with lifestyle-limiting claudication initially. No significant surgical history. She was on your typical vascular meds, aspirin, statin, and blood pressure control, and she was a daily tobacco user. On exam, she had non-palpable femoral pulses and Doppler DP signals. Her ABI showed moderate disease. So initially, we have a 70-year-old woman here with high blood pressure, coronary artery disease, daily tobacco use with claudication. So we counseled her on smoking cessation, continued her medical management, and encouraged her to do a supervised walking program. She came back to see us 6 months later. She had progressive claudication that was onto rest pain. She could not walk more than 50 yards. She was applying for handicap license plates, so she was severely limited and in pain. And so we obtained an arterial duplex in preparation for our angiogram. Our arterial duplex showed high-grade velocities in the right common iliac artery and left common iliac artery, indicative of hemodynamically significant disease. So we proceeded to take her for an angiogram with intervention. We did bilateral common femoral artery access, and we did bilateral common iliac IVL Shockwave L6 treatment with a 9 mm balloon. So this allowed us to appropriately size the balloon to her iliac arteries. We passed the balloon up each side and did multiple treatments on each side. And we then performed bilateral kissing iliac stents with 9 by 29 BBX stents and had to extend that right stent with a 9 by 39. So this is our initial angiogram. On the left, you see very stenotic proximal common iliac arteries. This on the middle screen is the post 9 mm Shockwave L6 angioplasty. You see a significant difference between image left and image center. And now we've positioned our kissing iliac stents. And then we have our post-deployment of the stents on both sides. Unfortunately, this picture that I have was shot from the patient right, so you don't see fully the contrast up and over on the left side, but you see significantly improvement even on that right side if you compare from screen left to screen right. And using the L6 9 mm balloon really allowed us to make sure our stent was going to open fully to profile. So 1 month post-operatively, she had resolved rest pain. She no longer had any claudication symptoms. She had palpable bilateral femoral pulses, palpable pedal pulses, and normal ABIs of zero point 0.9 and 0.98. 6 month post-op, she's continued to do well. She's ambulatory. She doesn't have rest pain, no tissue loss, and now has completely normal, non-invasive studies with an ABI of 1.1 on both sides. So both of these cases are just examples as to different applications of L6, when you would use it, when you would use IVL in the iliac space, and both of them provided, durable results for our patients in a safe and effective manner. Once they had failed a walking program and progressed to rest pain, we really had to go and treat this complex calcified lesion.